Okay, as I am about to welcome our first keynote speaker, I find myself reflecting back to our 2020 annual conference, where we welcomed Jack Dangermond, founder and president of Esri. I remember his keynote address where we were wowed and inspired by the latest mapping technology updates. Jack also highlighted a new map, one that was changing rapidly with new data and receiving thousands upon thousands of views each day. I'm talking about the COVID-19 case count map, the first one by Johns Hopkins. While most of us were vaguely aware of the new virus taking hold across the globe, Jack and the Esri team were busy and deeply involved behind the scenes to support making this map happen. The Johns Hopkins COVID-19 data is masterfully displayed in an Esri dashboard. Locally in Wisconsin and throughout the world, we've seen maps, services, dashboards, response hubs, and many, many more applications from Esri that support COVID-19 tracking during this pandemic. Little did I know at the time, the world as we knew it would change, and the 2021 conference planning process would change a lot over the following months. Our conference was supposed to take place in person at the Kalahari Resort in Wisconsin Dells, a venue we hadn't been to in years. As you all know, our conference has transformed now into a virtual event, which is still very exciting. Now, about our keynote speaker. Dr. Geraghty is the Chief Medical Officer and Health Solutions Director at Esri, where she leads business development for health and human services sector. Formerly the Deputy Director of the Center for Health Statistics and Informatics with the California Department of Public Health, Dr. Geraghty led the state vital records and public health informatics programs. There she engaged in statewide initiatives in meaningful use, health information exchange, open data, and interoperability. In addition to her degrees in medicine, medical informatics, and public health, Dr. Geraghty is also a board-certified public health professional and a GISP. As we have experienced an unprecedented year amid a global pandemic, there is no one better to deliver this year's keynote address to WLIA. I am honored and delighted to welcome Dr. Geraghty.
Thanks, Carmen. I appreciate it. Hi, everybody.
Hello.
My screen. All right, if you can verify that you are seeing my slides.
I can. It looks great.
Perfect. Well, I have to say it is such a pleasure for me to have this opportunity to share the morning with you. I do wish, like everybody else, that we could do it in person. And to be honest, as a physician, I never really imagined being invited to address the Wisconsin Land Information Association. So I am especially honored to be one of your keynoters for this conference. But I guess it just goes to show that we all have so much that we can learn from one another. So I'm going to do my best to add some value to your day by sharing a little bit of my own story, complete with lessons learned, and the work that we've done in supporting COVID-19 response across the globe and how that history sort of prepared me for this moment. So how does a doctor end up in GIS? Well, in many ways, I doubt that I'm really all that unique in the retrospective review of what was a circuitous and disorganized career path that actually led to exactly where I'm supposed to be. So I'm going to share some of the highlights of that journey with you in the first part of my presentation, and then I'll show how what I've learned along the way really supported our work at Esri in pandemic response. So clearly, when you have a winding and crisscrossed journey, you were probably traveling without a GPS. I certainly was. So I'm going to share with you some of the key moments along the way and the lessons that I learned. And you'll see those lessons actually encapsulated on the slide in light yellow text. And the majority of the pictures that I'm going to show you for this part of my presentation came from another epic journey that I took, which was my pilgrimage from Porto, Portugal to Santiago de Compostela in Spain. In other words, the Camino Trail. So lesson one, by the way, is to explore your own journey and make moves that are based on your specific passions, not what somebody else thinks you should do or should be. I promise not to delve too much into my childhood. That's kind of a joke, but suffice to say that I came from a working class family, probably somewhere around lower middle class in Orange County, California. And my parents did not have college degrees. They got divorced when I was 14 years old, and I started working that same summer to contribute to the household expenses. We weren't really well off, but we did always have enough, despite the fact that we had 2 bankruptcies that we experienced before I even turned 16. And I very clearly learned, at least in retrospect, that your circumstances do not necessarily predict how far you can go. In fact, I actually always felt empowered. I knew I was bright. My father insisted that I was going to be educated, and my grandmother instilled pretty significant ambition in me, as you can see by the slide. Such positive messages are actually really critical because people do tend to live up or down to the expectations that are set for them. But things did not always go smoothly in my career path. Starting with my educational path, I went to UC San Diego right out of high school, and my level of immaturity really showed. I did nothing but play. And I was actually asked by the school to please don't come back for the second year. So the lesson here, we all make mistakes, and you really just have to pick yourself up and move on from that. And so I put education aside for a while, actually. Instead, I took some odd jobs that taught me really valuable lessons. When I worked in fast food and retail, I got very quick, very efficient in the work, and good at making the customer actually feel important and cared about. I taught modeling school for a while, and I learned poise and confidence in just about any situation. And then I learned bookkeeping, which was a great opportunity to discover money management. I really paid great attention to detail, ensuring that my books always balanced to the penny. You want your doctor to be pretty detail oriented, so that turned out to be a good choice. I also managed the US Customs work for Mazda Motor of America, where I became pretty adept at process improvement in very complex and very bureaucratic processes. Finally, after about 7 years of dabbling, I decided to go back to school, and my restart began with community college, where I got an associate's degree in general studies. With my 4.0 GPA, I was the valedictorian that year, and I really liked that. So I went back and did it again the next year with another associate's degree in liberal arts and sciences. I was then getting started on my 3rd associate's degree when I was kind of pushed to stretch myself a bit by, in fact, the love of my life. I met Colin in my community college cultural anthropology class. And he's sort of this kind of natural life coach. And actually, he's now a certified executive coach, which he does on the side. But he guided me at the time through a career exploration exercise that helped me decide that I was going to pursue medicine. And he was and always has been incredibly supportive. And I can tell you that that kind of support, at least in my life, has been extraordinarily valuable, both for the notable insights it's created, as well as the sheer pleasure of having your very own cheerleader. Now I'm going to get back to the content here in a minute, but for now, I just want to note that while I was in community college, I was encouraged to join the speech team. And I chose to take that opportunity, and it really changed my life. This picture, by the way, is one of me being invited back to the college 14 years later to give the commencement address. Well, in the big scheme of things, my education progressed. I attended Scripps College in Claremont, California, where I earned a bachelor's degree in biology. But then I was initially rejected in my first round of medical school applications. In a second year, I was finally accepted at UC Davis. And I have to say, I call the whole medical school experience the great leveler. All medical students are bright. And so some of us that had always been at the top of our class would now end up somewhere in the middle or the bottom parts of the class. I ended up somewhere in the middle of my class. I soon discovered, however, that I wasn't as passionate about medicine as I would have hoped. So I added to my studies so that I could earn a degree in my second area of interest, which was technology. And I applied that medical informatics work to what was also a part-time job at the time. So an MD, a master's in informatics, and a part-time job in radiology research, where during that year, I was also able to publish 5 papers. So everything, as you can imagine, was going really well. I was very productive, having some fantastic mentors who really helped me and guided me through the process. And I was really planning on heading into a radiology residency for my specialization. But alas, things are never as easy as you hope they're going to be. After medical school, I didn't match for a radiology residency program at all. So I did what we call a prelim year in Utah, and I tried to join the Air Force because that was another route to get the residency position I wanted. But I was sadly rejected again. So I finally got into an internal medicine residency program in San Francisco at California Pacific Medical Center. But since this wasn't the actual specialty that I wanted, I started to experience a bit of burnout before I even completed the training. So I made another career shift. I decided to pursue a fellowship after residency that focused on healthcare research skills, including getting a master's degree in public health. And this training was really intended to lead to an academic medicine career. And this stage in my life, I have to tell you, required fortitude, or what you would call courage during adversity. And you really need that if you're going to be able to stick with it and eventually get to your goals. And things did turn around for me again in a very positive way. In my public health program, which was in 2005, I learned for the very first time about GIS. And then I actually did go back to school and get that third associate's degree that I had always wanted, only it was an associate's in science in GIS. And I did that while I was finishing my master's in public health. Then I secured an academic position at UC Davis, and that maximized my time in research and teaching. Both of those were focused on spatial epidemiology, which I absolutely loved. But the position also was a way to minimize my clinical responsibilities, which was great for me personally. So I went from being Dr. Geraghty internist to Dr. Geraghty mapping and informatics guru. So just when I was settling into my perfect career, a colleague of mine suggested, you should apply for this position at the California Department of Public Health and be their deputy director over the Center for Health Statistics and Informatics. But it really took me some time to decide if I was even open to the idea of change. In fact, I did apply, but it was on the very last day that that position was open. And you heard my bio up front. I ended up getting the job. And at the same time, I maintained my affiliation with UC Davis. And of course, as I am wont to do, I started a new 2-year fellowship, a leadership fellowship with the California Healthcare Foundation. I seem to like this idea of stacking educational and career opportunities on top of one another. Now, after years of work in health GIS, Esri came to me and recruited me to serve as their chief medical officer. And I've now been at Esri for more than 6 years, doing some work on the marketing and thought leadership side, as well as the sales and business development side. And I have to say that in that whole transition, while, as I mentioned to you, I wasn't in love with clinical medicine, it was really hard to give up the white coat. All of that training and all of that time that I spent in that career journey really led to my personal identity being tied to clinical care. But I learned once again that change can be hard, but we have to move on and not let it get us down. And I've had a lot to learn at Esri. Sales and marketing were completely new areas for me. I now had a team to lead and coach, and I had to prioritize what was zillions and zillions of ideas into a focused and strategic business plan. I've learned how to talk to the media in sound bites. I've learned that networking and relationship building aren't just fun times, they're that too, but they require effort and energy and good follow-up skills. And I've learned that humility is an important character trait. I came to Esri wanting to personally fix all of the issues that we have in health. And while you might say that this was pure hubris on my part, I'd say that it was probably just a reflection of my passion and the fact that whatever I'm doing, I really tend to go all in. Now at Esri, I get to work on so many of the important problems in our world today, from using GIS to address infectious and vector-borne diseases to social concerns like the opioid epidemic and homelessness, to even operational needs like strategic planning and marketing development in healthcare. We're always thinking of ways that we can help health organizations increase access to care or create sustainable development and improve community health. One thing that I really wanted to come back to, as promised, that I hinted at before, was what I consider to be my #1 skill, which is public speaking. Maybe you'll change your mind by the end of this talk, but hopefully you think I have a skill here. But I first got my training in public speaking on that speech team in community college, and I've taken advantage of speaking opportunities ever since. So to do this well, you need to believe, first off, that people actually do want to hear what you have to say. Improving public speaking and communication skills absolutely increases confidence under pressure. It helps with job interviews and successfully sharing your brilliant ideas with the world. People who speak up become more visible, and they are perceived as leaders and intelligent. And the great thing about public speaking and communication is that it is a learnable skill. Besides being on the speech team, I also joined my local Toastmasters club, and I accepted all opportunities to speak that were offered to me. And eventually I started to teach others about public speaking, and that only improved my own skills. Now, one of my key pieces of advice for those who are not yet confident speakers is definitely fake it till you make it. Kind of similar to the well-used quotation from Mahatma Gandhi, which is, be the change you want to see in the world. To be a great speaker, act like you are a great speaker. Now, once I mastered public speaking, I began building some complementary skills like learning emotional intelligence, organizing my life, and managing my time. It's so much easier to develop new skills if they have some kind of a relationship to skills that you already possess. So as I sum up the lessons learned from my crazy career path, I'll simply say that no education or training is wasted. In my career, all of the credentials that I've accumulated matter. They make me credible. I have had a lot of setbacks and uncertainty in my career, and I've learned to be pretty okay with those things and not fear change so much. I try to live by my own passions and keep learning all the time. And I've never settled for having just one mentor. I have several who help me in so many different ways. So whatever you do, enjoy your own journey, because it's definitely about the process, not so much the destination. Although at least one destination seems pretty relevant in my career. So let me now transition to sharing a bit more information about the GIS response to COVID-19. Mapped information has, of course, been front and center during the pandemic. You might make the argument that GIS has never been more important than it is right now. And Honestly, it makes sense when you think about the roots of GIS, something that another one of my mentors, Jack Dangermond, talks about frequently. This is a technology that's based on geography. I know you know this, but geography is the science of our world, and it provides all of that rich content of our world. So for me, I think about the biological content and the ecological content and the sociological content, but it really is all of the ologies that you want. And that content, so importantly, is put into context by using a common reference system of geographic locations. And the geographic lens really helps us to more easily see and digest complexity and relationships and patterns, something we've had a lot of in the last year. And I think this is also a part of why people really love maps. They get it. And this science brings it all together in the most remarkable way, and it helps us to understand, and it helps us to intelligently respond. And as I like to say, GIS helps us go beyond just collecting the dots to actually using place and location analytics to connect the dots in ways that create new insights, information, and they inform our actions. So I want to share a number of innovations organized across 4 different patterns of use that we're seeing deployed in really impactful ways to respond to COVID-19. Then I want to show you how these same patterns apply to other health challenges that we're facing in our communities and in our countries. If we're going to gain anything from these incredibly challenging times, it's going to be the lessons that we've learned and applied to make us more resilient and more responsive going forward. So let's begin with mapping and monitoring disease. Now, it's been mentioned already, this is a familiar sight, I'm sure, for everyone, the world famous Johns Hopkins University dashboard. I personally first came into contact with this dashboard on January 23rd of last year after seeing a tweet from the JHU team. Now, my whole team at Esri checked it out, and we were all actually really impressed by this dashboard's clarity of message. And I guess we weren't the only ones, because the dashboard had tremendous uptake. It quickly became a backdrop in operations centers around the world, from the US Health and Human Services Secretary's Operations Center to emergency response meetings happening in Germany, coronavirus briefings going on in Italy, and you can even see it in the background in Ireland, among so many others. And the influence of this dashboard broadened when respected journalists started writing about it, and that coverage was quite extensive, but some notable examples included the New York Times, BBC World News, and actually our own Esri website used it for a landing page focused on COVID-19 resources. And the story of the dashboard was featured on National Public Radio, in Science, Nature Index, the Wall Street Journal, and in many other publications. And I was actually even invited to talk about the dashboard and mapping of coronavirus on CNBC News. Now, the dashboard went viral very, very quickly. This graphic is showing you the first 3 months of feature requests starting from the dashboard's introduction. So I just want you to take a really close look at that scale on the vertical axis. Each division is actually 500 million feature requests. And then what you're seeing at a peak in late March is this dashboard having been requested 4.5 billion times per day. I mean, really compare that to the current world population and you're going to get a sense of how remarkable these numbers are. And now I can tell you that it has been viewed trillions of times. So let me mention some of what I think are the key outcomes from this JHU COVID-19 dashboard. First, it broadly demonstrated the value of GIS for health applications to a global audience. Second, the fact that the JHU team put data sharing first was a huge enabler that helped all kinds of organizations, including health organizations, to visualize, analyze, plan, and make better decisions in their local COVID-19 responses. So this really is what open data is all about. And here are just a few examples with dashboards from New South Wales and Indonesia and all of the Australian states. And you can also see an example from Ireland and from New Zealand. I mean, this idea really took off, and thousands of organizations designed their own dashboards, and they did it all slightly differently to provide the most relevant information for their population. So getting back to the contribution of the JHU dashboard, their data, by comparison, I would say really exposed gaps in our public health systems in collecting and sharing data with the public, and it exposed a lack of interoperable systems that could provide a cogent national picture, something that we really needed. All of this, I would say, really inspired a lot of questions about who really should be an authoritative data resource when you're in a situation like this. These kinds of questions, I think, are really critical points of discussion that have the potential to enhance public-private partnering and improve our capabilities as we come upon whatever will be the next crisis. And the JHU dashboard, because of its regular updating, built expectations, I would say, among all of us for real-time and near real-time data. And if you didn't realize it, we have never had real-time data feeds in health before. So this is a completely new expectation. And I have a feeling that all of these things are really going to help push technology systems forward in very desirable ways. Now at Esri, we were also enabled by the JHU data. We developed several examples of monitoring trends, like this map that came from my colleague, Charlie Fry, and it shows county-level trends in the US according to the 5 pandemic phases, where the pink colors indicate high case numbers or high case rates. You can see that at this time, this was a screenshot from yesterday, most of the US still remains in epidemic phase. Now, John Nelson built this app called COVID Pulse that uses spark lines to show really what is the full history of case rates or death rate trends from the beginning of the pandemic in the US. I especially love this map since I personally think the spark lines kind of look like EKG tracings. So we really do get the pulse of the situation in the United States. And you can also zoom in to see the county level detail. And the very talented Jim Harries at Esri created this map with gold arrows to show improving trends and purple arrows to show worsening trends. So from this map, you're seeing something different. You can intuit that while the case numbers are still high, like Charlie's pink map showed you, the direction of change is toward improvement with a predominance of gold showing up across the country. The JHU data has been pivotal to understanding and decision-making. Now, there are countless examples of how health organizations have been mapping and monitoring disease to give them a better handle on what their populations are experiencing. Certainly, infectious disease surveillance is perhaps the most common area of work, from mapping malaria transmission in Kenya to detecting the presence of African swine flu in South Korea. But many are also mapping chronic diseases like cancer and diabetes, obesity, smoking and drinking, and much more. Understanding the impact of context on health is another prevalent area, like looking at lead poisoning or low birth weight babies. And we also see more and more efforts focused on operational workflows, like monitoring wastewater for the presence of opioid medications or monitoring patient flow in a hospital as they're doing in Argentina. Mapping and monitoring disease is a great place to start for GIS in health. Next, we're going to dig into analysis, which is one of my favorite areas because I think it's sort of like being a disease detective. You're figuring out where's the problem, where's it changing, what are the underlying causes, how can we improve outcomes or forecast what may be coming upon us next. Well, a common analytic function in health is about understanding gaps in services or gaps in health outcomes by figuring out first who is more or less likely to be affected. So people who are more likely to be affected, negatively affected, are considered vulnerable populations. So let's think about this with COVID-19. People could be vulnerable to COVID-19 for a number of reasons, and we can actually visualize those. Maybe it's older age or medical comorbidities that make some more susceptible to having severe disease. People may be vulnerable because they're essential workers and they're more likely to be exposed to the virus in their job. Or perhaps the vulnerability is because they live in congregate housing situations like nursing homes, university dormitories, or prisons. We can overlay those various vulnerabilities to find the highest risk places for COVID-19. Now, we also used analysis to perform capacity forecasting. So this is where we used a model that could take hospital bed utilization data along with social distancing behavior data and understand what might happen over time with local hospital bed capacity. Because of course, every hospital and government wanted to be able to predict whether their curve was going to stay flat, which would maintain the health system's ability to care for each and every person that walks through their doors, or if some hospitals may become overwhelmed and exceed their capacity to provide the best care. Now, Harris County, Texas was looking at accessibility of testing sites for COVID-19, and they coined a new term from their analysis, similar to the idea of food deserts. They detected testing deserts in their community where people just didn't have good access to get tested for the virus. And of course, you can go really deep into analyzing relationships using GIS. I love this example looking at social distancing and weather data in California. So the bars you're seeing are the social distancing grades over time from aggregated cell phone data, where red is an F and blue is an A. Then we put in the dates that California had its stay-at-home order go into effect. So under that, you can see nobody was social distancing, but afterwards, our coastal counties were doing really well. The inland counties a little less well in their social distancing behaviors, but they made some solid efforts. Well, then we saw something happen in April. On April 25th, crowds started to form at the beaches. So you want to develop understanding, right? And you figure out why. So we decided to add another data set here to understand. So we pulled in weather data from NOAA. And then we built that data up using voxels to get a picture of weather over time. So the darker orange-brown areas are warmer temperatures, and the bluer areas are cooler temperatures. So now we can dig in and really start to make some comparisons. Now remember that Esri headquarters is in Redlands, California, which is in San Bernardino County. So in just a second, we will focus in on that county. So here we go, and let's see the relationship. Seems that there is a clear relationship between warmer weather and less social distancing. So I know that wasn't any of my Esri colleagues, but other people in San Bernardino County seem to make their way to the beaches. But this is just one way to get a deeper understanding into what's going on in a particularly challenging area of behavior. So I'm sure that I could go on for days and days about how this pattern of analysis applies to health concerns outside of even COVID-19. Around the world, there's a lot of effort to use mapping to better understand racial and ethnic disparities or notable vulnerabilities like they're doing in Finland. In Lebanon, they're using mobile survey tools to better understand the lived experience in disadvantaged neighborhoods. Across Europe, there are efforts to look at civil unrest and identify and manage the pockets of unrest, especially in areas of high COVID case counts. GIS can really make the complex more simple. kind of like the risk factor map that you're seeing for homelessness. Now, by understanding that certain areas experience more homelessness because of unemployment, while other different areas are generating homelessness because of domestic violence, we can start to put the right interventions in the right place to help solve the problem. I also really like the analysis of 80s mosquito habitats around the world, partly because I was involved in that project, but it helps us to really better understand and plan mosquito control efforts so that we can present Zika virus, dengue fever, and chikungunya, to name a few. Now, the third repeatable pattern that we see a lot of for COVID-19 is strategic planning. So I'll spend some time here. As I'm sure you're very well aware, two staples of geographic problem solving are site selection and calculating the geographic accessibility for places. And these methods have been used for things like standing up new testing sites, distributing food resources, and extending healthcare services in those places where the hospital capacity actually does become overwhelmed. Now, this process uses location allocation. So let's say that we wanted to stand up some new testing sites in those places that I showed you in Texas that were testing deserts. Well, for COVID, we'd begin by determining population demand, or you might say the population need for this particular service. And we can do this by what I was talking about before, overlaying all of the factors that are contributing to each of the 5 COVID risk types: transmission risk, socioeconomic risk, susceptibility to the disease risk, exposure risk, and resource insufficiency risk. In the end, these create a risk ranking, and you can do that over small geographies of your choice, like neighborhoods, for example. And then to calculate the best testing center locations, you apply those risk rankings along with road network data so that you can calculate drive times and drive distances that would be reasonable for access. And then you can input any other kinds of constraints you might have, like maybe you only have a budget for 10 new testing sites or limited staff that would be able to support 5 new sites. So the model takes all of that information into consideration, and it selects the most optimal sites from the entire population of options that you make available. Well then, once you've got new testing sites, how do people find the resources that they need? Well, of course, they use resource locators like this one that comes from Valencia in Spain. When placing a pin on the map, the user can get information about the nearest hospital, pharmacy, social services, or testing sites in their area. So there's no question that COVID-19 inspired great innovation in health, allowing people to connect the dots to support the response to the pandemic. But even going a step further, we saw GIS used in this one example. It was a large-scale COVID-19 testing that was done last fall in Slovakia. Now, they aimed to test the entire population, adult population, over 2 weekends in October, 3.5 million people. And GIS actually provided residents with up-to-date wait time information. So that data really helped people to self-distribute, because nobody wants to wait in long lines, among all the different testing sites that were available. And that regulated overall occupancy at each site. It improved social distancing and was really a win-win for everyone. Now, when we think about tracking our capacity to respond to a pandemic, it really goes beyond forecasting hospital beds and ventilators, but it also includes the availability of personal protective equipment. And we can use simple survey tools that are connected to dashboards, which, by the way, turns out to be a very powerful combination in health. And that helps hospitals, for example, to collect and manage their critical supply inventories. You can do that for each hospital within a health system, and they could report that information up to regional or national governments so everybody understood who needed PPE. Now, I'm going to take a few minutes to dive just a little deeper into 2 important strategic planning areas that are going on right now. contact tracing, and planning for vaccine distribution. As you may know, contact tracing is a process that health departments perform, nothing new. We've been doing it for decades to help break transmission chains before an infected person has a chance to spread their infection to others. So I actually became a certified contact tracer this last year to make sure that I understood the process well. We're using GIS to help health departments collect and manage their contact tracing data, to do rigorous analytics, and to evaluate their processes. Now, this is a sample contact tracing form from the CDC, and there's this section called the Exposure Information section, and I've got that blown up for you a little bit on the right. And it asks questions like, have you traveled domestically in the last 14 days? So if the answer was yes, then the contact tracer is supposed to fill in which state you visited. Well, we in this audience all know that states are pretty large areas and that level of location just isn't very useful. So we developed apps to make gathering finer scale location information, as well as conducting actually all of the interview questions, really easy. Now, once you have the data, they're all collected, health professionals are going to need to be able to perform analysis. And this is especially important for COVID-19 because a lot of the viral spread happens by community transmission. In fact, we actually even coined a new term for this kind of analysis. We call it community contact tracing. And basically what it means is that people who get sick can't always identify how or by whom they've become infected. So we need more information in the contact tracing process. So we start with the locations that we collected in the contact tracing interviews. And we can take that information, even if they did it separately and it comes on a simple spreadsheet, right? And we can put it on a map, marking the very first step in a spatial analysis. Now, the first analytic function that you might want to perform is density analysis, which is visualized here as a heat map, possibly providing early clues about higher risk locations. The spot that's actually lighting up in this example is a nursing home. Now, moving on to link analysis gives us a better understanding of person-to-person connections that are that traditional focus of contact tracing. But there's an and here. And we can use tools from graph theory that help us to determine the strength of person-to-place connections that are so important when we're talking about something like this, community spread. And of course, we can use dashboards as a way to evaluate and improve the contact tracing process. By monitoring how we're doing, we can help with identifying and coaching contact tracers that maybe aren't keeping up, or we can hire new contact tracers if the workload is the problem. Or maybe we'll even be able to identify other bottlenecks in the system, which could impact its efficiency and effectiveness, because this system has to run quickly or it pretty much means nothing. Now I want to spend some time talking about the area that, frankly, I think gives us so much hope nowadays, and that is vaccination. So there are 4 key steps to the vaccination distribution process. We start with ensuring access so that everyone can reach a point of distribution in a reasonable amount of time. And then anticipating demand is really about having the right capacity in each location to meet population needs. Then we'll talk about tracking progress and monitoring performance metrics that are related to the efficiency and especially the equity of the process. Tracking can also help us uncover regions where vaccination uptake might be low. And then we can feed that information back into the process to adjust access and demand resources as may be needed. And finally, we can enhance communications by providing public information about eligibility and nearby resources and do it in local languages. So as you know, ArcGIS supports all 4 of these steps in one integrated and interoperable set of tools. So let's dig in with step 1, ensuring access to your points of distribution. Now, this really requires two major pieces of information: the distribution sites and the population they're intended to serve. So first, one has to map the suitable locations for vaccine distribution. We'll call these candidates. This is going to include hospitals, clinics, and pharmacies to start off with. Now, it's really important to identify key facility capabilities, like the availability of ultra-cold storage freezers. There may be other factors that would support facility planning, like access logistics, such as ingress and egress, or for those drive-through vaccination clinics. Or it could be that you're looking at parking, facility size, and nearby traffic conditions so that you don't end up creating a new bottleneck in the community. It's also a really good idea to identify additional candidate vaccine delivery sites if more capacity is going to be needed for later stages of the process, which I can say most certainly will be the case. Now, the second part of ensuring access is to map the population in whatever kind of phased approach the state or the local government is pursuing. It could be age cohorts, essential job functions, or prioritizing various aspects of social vulnerability. Now, once you have the vaccine sites and the population mapped, ArcGIS can provide some valuable insight. For example, from your list of candidate vaccination sites, the analytic tools can assess the population locations, travel distance to facilities by walking, driving, or public transportation, and any number of other factors which would help identify the sites most optimal for serving that population. So location allocation again. I think the main lesson here that is a different approach than maybe you're reading in the newspaper or listening to the news is you don't necessarily need more sites. You need the right number of sites in the right locations. And the analysis is actually also going to show you gaps in your network, like the red areas that are highlighted here, showing communities that cannot readily access a vaccination distribution site, and they might benefit from a new resource being placed in that area or some other outreach method. But this is a global problem, right? So what if there's a place that doesn't have optimal data for calculating a travel time? Well, we can actually use alternative methods considering elevation, slope, and land cover to calculate the difficulty and thus the time it takes to traverse various types of landscapes. So this is the example that used that particular method for the country of Uganda. So while geographic access is very important, we think our second step, anticipating demand, is also really critical to plan for the workforce and other capacity issues that are going to be required to actually deliver shots into arms. How many people can each site vaccinate per day or per week? We know the president wants to do 100 million vaccines in 100 days. So you got to be able to calculate in that way as well. So this is going to tell me if I have to hire more people, arrange for more supplies, and it helps me to estimate when potentially vaccine-induced herd immunity could be reached. Now, the third step is to track progress. I never have a presentation without a bunch of dashboards. Sharing progress with the public can be a great source of motivation and encouragement for that community to go and get vaccinated. And it also helps with the internal organizational decision-making process. So for example, if we see that a region or a specific site is underperforming, we can take corrective action, and we can monitor the fairness or the equity of our process and make adjustments if needed. Enhancing communication is our fourth step in the process, and it's a really big one. ArcGIS Hub, it turns out, is a great tool for that because it can contain within it information and several apps that inform people about how, when, and where they can get their vaccine. As you know, easily accessible information can also build trust, and it can curb vaccine hesitancy. And ArcGIS Hub, along with our other applications, are supported in dozens of languages. So let's take a look at one of the apps contained in this Hub solution. It's called Am I Eligible? It can literally be deployed in a few seconds using one of our solution templates and modified at will. A person simply launches the app and answers a few questions to determine if they're currently eligible for vaccine. If they are, then the app will guide them to the nearest vaccine provider. But if they're not eligible, you can use ArcGIS as a kind of pre-registration system and collect information from those interested individuals. Then as you expand eligibility, you can pull names from that list for some kind of a notification, or you can add their names to an existing registration system. Now, the Vaccine Locator app is another one of the solutions that we offer, and it can enable providers to report wait times like we saw in Slovakia, and vaccine availability in near real time. Make sure they still have vaccine when you're ready to go, so people can plan their day and avoid wasting time. And I think this is important not just for the convenience aspect, but it's really a component of people's willingness to get a vaccine if they think that it's going to go smoothly. Now, also related to this really important idea of overcoming vaccine hesitancy, we can filter population data based on research like from Pew or the Kaiser Family Foundation to predict which communities may be more prone to concerns about the vaccine, and then deploy additional outreach in those high-risk areas. Now, that might involve growing community partnerships in specific regions, and local level infographics like this one, which is available in ArcGIS, supports strategic outreach from those community partners. So I think this is a really great example of data driving action. And further, we can use data to identify areas where people fail to turn up for their second dose of vaccine. Now, this could happen for any number of reasons. Maybe something like there was a mobile clinic that got moved before people received their second dose. Well, GIS can help identify those areas and even leverage demographic data in yet another way to create more resonant messages by understanding the population and delivering them through the most relevant channels that that local population uses, and also considering what languages are predominant in that area. So I wanted to show you just a few of those ideas in practice. In New York City, their COVID-19 vaccine finder shows the public where they can find their closest vaccination site, and it provides a direct link to their scheduling system for each site. It even displays what brand of vaccine is available at that location, so that if you go somewhere else for your second dose, you can still make sure you get the right vaccine type. This is a lot of talking. In Lebanon, the Ministry of Public Health is collecting survey data on hospital readiness to receive the Pfizer vaccine. And they're asking questions about cold storage capabilities and how many personnel are available to deliver the vaccine. So these same ideas are recurring. In their next planning phase, they're considering the pre-registration for the first dose of vaccine and a second dose notification system to ensure, again, that residents do get their full series for adequate protection. And here you can see the stage 1A vaccination tracking process in Panama. They call this the vaccinometer, and it is public for anybody to review. So we see these 4 steps as needs that everyone has, but geography can also support other parts of the process. For example, we can help with tools for site planning and crowd management at the vaccine venues. We have tools to help you track your supply chain to minimize the impact of any disruptions that could occur. And even some back to work needs like a COVID-19 screening questionnaire for employees and visitors to your buildings. And we've also configured an inventory management system for vaccine and supply kits that reads the 2D barcodes on the vials and is really easy to use. Now, strategic planning, this large area in health, or actually in any other sector, is really about applying whatever limited resources we have in the most effective ways possible. Health facilities are being cited in Kenya, Oklahoma, and Japan. And then many are focused on getting people to their healthcare appointments. So we see planning efforts to provide public transportation and ride-sharing options. And nowadays, health organizations want to consider providing services digitally through telehealth or e-health options. Folks are using GIS then to determine if there's sufficient need for those kinds of services by assessing the travel burden across their populations. They might also check to see if the broadband coverage is adequate for those kinds of services. And by the way, this is also a general measure of digital equity that can be applied to understand where greater investment might be needed to support general digital access and education services, to name just a few. And finally, in this telehealth process, GIS can support these services by informing which health service offerings are going to be most needed by that underlying population. So the last of the repeatable patterns that I wanted to cover this morning is indoor space management. With COVID-19, we know that disease transmission occurs more easily in enclosed spaces. So this topic becomes extremely important to consider. In fact, as we've seen in numerous studies, sharing indoor space is a major SARS-CoV-2 infection risk. While organizations are faced with many important decisions as reopening efforts eventually get underway, maybe the most important question of all is, how can we prioritize health and safety inside our buildings? A lot of organizations are paying close attention to indoor space planning in order to bring employees back to workplaces or to reopen restaurants or schools or universities. ArcGIS Indoors is being used to analyze seating arrangements and spot areas where we don't have at least 6 feet of physical distance between the workstations. So you can see that in this map in the areas in red. And once you know this, you can actually be really efficient in making the proper adjustments. Inside our buildings, there's no doubt that we're going to need to pay better attention to sanitization, whether we're placing new hand sanitizing stations or we're planning disinfection procedures for janitorial staff. We need to be able to make service requests easily from mobile devices and monitor our progress in one place. And we also have the opportunity to track devices in our buildings and the surrounding areas if we have a campus. Now, by doing this, it becomes really easy to spot potential problem areas where there may be high traffic or prolonged dwell times. And actually, if an infection arises in our buildings, we can use this proximity tracking to support public health contact tracing efforts. The indoor space management pattern is the newest of the patterns that I've shown you. Even so, we're seeing the concept of indoor GIS provide great value for health organizations. The effort could be really just as simple as visualizing an entire hospital campus, like the BIM model that you see from Norway. In Indonesia, they're using their building models to ensure safe evacuation in the event of an emergency. And large campuses like Harvard University or University of Toronto are making navigation very easy. So this same use case is really critical for hospitals. I mean, for any of you, and probably most of you who've ever been in a hospital, you know what I mean. They are always confusing. So one of our hospital customers, Loma Linda University Health, has not only improved indoor navigation in their hospital, but they've also worked on managing patient flow through their clinics to improve efficiency and patient satisfaction. So there are lots of opportunities to bring indoor GIS to the world of health. It's been a rough time. I'm sure that's an understatement for many of us in our history, and it's not quite over yet. So we really need to keep the GIS innovation going in the health world, because it's never actually been enough to simply collect the dots. Technologies like GIS support health by helping us to connect the dots in ways that inform and inspire and initiate change that I hope makes us all healthier. So I hope now that it all makes really good sense. My journey into GIS from a medical and public health perspective, and the way that we apply this technology to the broader needs in health, as well as the current focus on the pandemic. After all, the concept of place being important to health is actually nothing new. The father of medicine, Hippocrates, after whose teaching I took a sacred oath, knew this all along. Where people live and the environments around them have a significant impact on their personal health and outcomes. And I want to say thank you so much for your attention today.
Thank you, Este. What a great keynote presentation. Thank you so much, Dr. Geraghty. It was absolutely perfect for WLIA.
I'm so glad. As I said, I never imagined I would be invited to your organization. So thank you for having me. And like I said, I hope it adds some value to your day.
It was wonderful. Thank you so much again.